Good afternoon. As Dr. McKinsey said, we changed directions a little bit. I think any vascular conference you go, either across the country or around the globe, I think we all have now standardized treatment for aortic infection. How do I move the slide?
Green.
So there's certainly a large amount of literature and experience, whether it is aortic graft infection or endograft infection or even infection of the native aorta. Now we actually have standardized the treatment. In the beginning, perhaps about 20 years ago or before, we thought Salmonella was the main organism. We were all taught during our fellowship and residency that this organism had special predilection for aortic plaque, but now we know that any other organism also can be the source of infection, particularly Klebsiella, Proteus, and other organisms. And of course, the treatment strategy is also well known. Either, of course, we have to explant the graft if there's a graft, or debride the aorta if it's a native aorta, wash out, and then, of course, in situ reconstruction with the rifampicin graft, as just was shown by one of the presenters just a few minutes before, or cryopreserved cadaveric human allograft, or neo-aortoiliac system with harvested femoral veins, or closure of the aorta and extra-anatomic bypass. So depending upon each experience and the local factors, these are the management strategies. So, however, these are all for bacterial infections. We actually don't have much experience in literature about the fungal infection, and I just want to show you an example of a case that we recently had. There's a 41-year-old man with worsening claudication, blue toe syndrome, and this was all done outside of our hospital. Angiogram revealed about 95% stenosis of both common iliac arteries. The surgeon outside did thrombectomy with the aortoiliac segment, but he was unable to get complete good flow, so he placed kissing stents in both iliac arteries, and he did well. And at that time, he also found that he had no pulse in the left foot. There was an angiographic demonstration of a popliteal artery occlusion. He exposed the femoral artery, did a thrombectomy of the femoral artery, and got only a tiny amount of thrombus. And completion angiogram still revealed popliteal occlusion, but he accepted it since he didn't have anything more to do. 4 weeks later, patient presents with acute ischemia of both legs. He has got bilateral, so the surgeon outside did bilateral groin cut down. He was unable to do thrombectomy, but however, he was able to pass a catheter to do the angiogram, and this is what it shows. The aorta is occluded all the way, actually above the renal, with some amount of limited flow to the SMA. He was able to do a little bit of thrombectomy, but as you see, he still was not able to successfully open the aortoiliac system completely. This actually made him to do open exploratory laparotomy, longitudinal aortotomy, thrombectomy directly from the aorta. Then he was able to restore the flow to both renal arteries and SMA, but limited flow to the iliac artery. He closed the aorta and did further stenting. He already had stenting in the iliac. He did additional stenting. Aorta was closed, and then the patient did get Doppler signals in the foot, and he accepted that at that time. About 4 days after this operation, patient developed signs of stroke. A CT head showed that he had an developing infarct. At this point, he was transferred to our medical center. Fortunately, the vascular surgeon outside, when he did the aortic thrombectomy, he had sent the thrombus for pathology, and the pathology came back as a fungal mass. So at this point, of course, he is now being transferred to our place, and here we, of course, did a new CAT scan, echo, and this is what it shows. We can see the air around. Of course, you can see the stents in the aortoiliac system. There's an air around the aorta. He also had an echo vegetation in the mitral valve. So at this point, of course, this case gets more complicated. Mitral valve was replaced by our cardiac surgeons first, and 2 days later, we had to go in, do an exploratory laparotomy. Essentially, the aorta appeared to be extremely disintegrated, so we had to resect the aorta and the iliac segment, remove all the stent grafts that were already placed inside, and then replace it with a cryopreserved allograft. So this is the picture. As you see, the aorta looks like it's almost getting disintegrated there. This is the this is the graft that we have removed from the iliac system, and this is the piece of the aorta and the iliac that we removed. And we, of course, reconstructed the aorta with cryopreserved aortoiliac system. This is the operative picture. We're all very happy. And to our surprise, all the specimen from the cardiac surgeon who did the aortic mitral valve replacement and the aorta that we resected, everything actually grew aspergillus. This was a fungus. The pathologist called us and said, this is growing aspergillus. And of course, we also did thrombectomy of the popliteal artery since it was still occluded. And to our surprise, the popliteal artery appeared to be disintegrating, and so that had to be resected, and a vein graft was interposed. All of them actually, all the specimens grew Aspergillus fumigatus. And this is a slide from our pathologist. As you can see, the hyphae, this is a special stain showing hyphae. So obviously, at this point, we called our ID people, and they recommended IV mycofungin and lifelong voriconazole for him. So we were happy. About 3 months later, he got readmitted. I'm going to make this a little faster. He was readmitted with recurrent mitral valve vegetations, and he was also readmitted with ischemia of the leg again. And to make a long story short, CT scan showed a new pseudoaneurysm of aortic anastomosis, a new vegetation in the mitral valve, and then all these had to be, and he had a new replacement of the mitral valve. We had to go in and remove our graft, close the aorta, do an external anatomic bypass. He develops a visual defect at this time. Ophthalmology was called, and we find that he has an endophthalmitis. Ophthalmology said that this is a fungal endophthalmitis, and they had to do infusion of the antifungal infusion into the eyeball. So this was initiated, and on the third or fourth time he went into the ophthalmology department, he became lethargic, and to our surprise, very quickly sort of became unconscious. CT scan showed a massive intracranial hemorrhage, and this was considered to be due to rupture of the intracranial artery that was infected by the fungus. So at this point, of course, comfort care was initiated after discussing with the family, and this was the case. The reason we are presenting this case is, of course, we all are familiar with a lot of bacterial infection, but we don't know much about the fungal infection. And this was unique. First of all, this was a healthy man. He had no history of transplantation. He had no cancer. He had no radiation. He was not on immunosuppressive drugs. And in fact, our ID experts were unable to explain why he got this disseminated fungal infection. And in fact, his case is being sent to the NIH to see if any one of them have any other advice. So we obviously don't have much literature in the vascular field. All the information we can gather from the cardiac field. And so fungal infection or fungal infective endocarditis accounts only for 1 to 2% of all the infective endocarditis. This is valvular endocarditis. The most common is candidiasis. Aspergillosis is the next most common, though it's very rare. But the problem with aspergillosis is the angioinvasive. It's just not a fungal mass or an embolus sitting in the aorta. It literally digests or eats the aorta or any artery that it gets infected. Aspergillosis flavus is less frequent. Widespread infection of the various segments of the arterial system, despite antifungal treatment, is extremely rare. The reason we are presenting is to see if any of the experts have similar cases so that we can share our experience. Thank you for the privilege. Thank you.